focuses on neurological manifestations and neuroimaging. It is my pleasure to introduce Dr. Vamshi Krishna, an accomplished neurosurgeon with vast experience in diagnosing and managing neurological disorders. Neuroimaging plays a very vital role in differentiating neurotuberculosis from many mimics. And today, Dr. Vamshi Krishna sir will help us understand the neurological spectrum and characteristic imaging findings. Vamshi Krishna sir has an expertise in neurological disorders spanning general surgery, super specialization in neurosurgery, and internationally accredited fellowship training in endoscopic brain and spine surgery. Currently, he serves as a senior consultant at Care Hospital, Hyderabad, one of India's foremost tertiary neuroscience centers. His key clinical competencies include endoscopic spine surgery, full endoscopic transforaminal discectomy, and interlaminar discectomy, endoscopic foraminectomy, decompression, and minimal invasive fusion, brain and cranial surgery, keyhole craniotomy, ETV, and others. Supratentorial, infratentorial tumor resection, has a good academic and leadership contributions. Is a medical educator. His peer-reviewed publication includes endoscopic spine surgery, ENHAM, rare case report, missing mesoappendix, post-traumatic hydrocephalus, and a list of other good publications. Over to you, sir.
Good evening, sir. I hope everyone, respected chairperson, distinguished faculty, and dear colleagues. It's an honor to be part of this CAHO webinar. Today, I'll be speaking about the neurological manifestations and neuroimaging in the brain. Because neurotuberculosis remains one of the greatest diagnostic challenge because it is often mimics the tumors, abscess, and other neurological disorders. So, through a series of real clinical cases, we'll explore how neuroimaging, clinical judgment, and timely surgical intervention can significantly improve patient outcome. So, as already Dr. Pratik has informed everything about the pulmonary TB global statistics. And the pathogenesis, as we all know, the step one, it would be in the primary pulmonary infection. From there will be a hematogenous spread. From there, again, it goes into rich focus formation and into the CNS manifestation. So how do the spectrum of neurotuberculosis? It is in the meninges. In the meninges, it is a tubercular meningitis. In tubercular meningitis, also there will be chronic tubercular pachymeningitis. When from the meninges, it moves to the parenchyma, they present as tuberculoma, miliary, brain abscess, and tubercular encephalitis. When from parenchyma they shift into the down to the spinal tuberculosis, they may even present as intramedullary tubercular myelitis and tubercular arachnoiditis, and most commonly they present as spot spine. Miscellaneously, they can in CNS they can be present as hypophysitis, orbital TB, otitis, TB of skull and base of skull, and also TB iris. So, as already discussed, clinical manifestation, if it's in the brain, they present as headache, seizure, stroke, altered sensorium, and raised diabetes. Whereas in spine, they present as back pain, weakness, radiculopathy, bladder dysfunction, and kyphosis. So, if you ask a patient for spinal tuberculosis or cranial tuberculosis, for patients suspecting them, especially TB meningitis, it is recommended to undergo a comprehensive MRI protocol. In that one, T1 first is the T1 MRI. T1 it is for the anatomy. T2 for lesion characteristics and also the edema. Flare is to suppress the CSF signal and to look. The most important in TB meningitis or TB abscess or pyogenic abscess ruled out is by the diffusion. And SWA to rule out any spectrum in the visual loss. And we get an gadolinium enhanced T1 echo, that is TAC, and flare imaging. They help detecting subtle leptomeningeal enhancement and also enhance exudates and tuberculomas. 3D sequences for the cranial nerve involvement, and where tuberculoma presents atypically, then you have you're confused between abscess and other patterns. Then we get an MRS to prove which is more beneficial. Other modalities like MR venography, MRA, and also the newer modalities, the post-contrast vessel wall imaging. They also detect vasculitic changes before infarction occurs. This is the newer one. So directly I'll jump into the TB meningitis. So TB meningitis clinical features, they present as subacute headache, fever, neck stiffness, and cranial nerve palsy. Third, 6th, and 7th are the most common, and altered consciousness they present. And if not treated in time, they present as complications like hydrocephalus, vasculitis, SIDH, and spinal arachnoiditis. So in the imaging, the pathological hallmark of TB meningitis is the presence of viscous and gelatinous inflammatory exudates in the meninges. So with a loose fibrin network, neutrophils, mononuclear cells, red blood cells, and varying amount of bacilli are present in this exudates. So if you can see in this diagram, so this is a basal system. Okay, ideally it should be filled with CSF and it should be very clear CSF. When it attacks by the TB meningitis, this becomes very thick gelatinous exudates because of the fibrin network, neutrophils, and everything. So at this basal cistern, there will be optic chiasma, cranial nerve 3, 6, and major basilar arteries, and pons will be present. So imagine this is a normal CSF flow. You can see the bluish coloration. So from here, the CSF flows very easily and it will be no compression. In cases of tubercular meningitis, because of the exudates, they block the CSF flow. Here you could see that it is blocking the CSF flow. Then they present as hydrocephalus. So they present as TB increase with the CSF pressure. They present as communicating hydrocephalus. Because of the TB meningitis, the compression of the exudates, they also present as cranial nerve palsies, and the compression of the major blood vessels, they present as vasculitis and also infarcts, and overall they present as raised ICP. When you come to the imaging, if you get a CT scan, as we already saw in the previous diagram, this is the basal cistern. When you get a CT brain, you could see there will be slight hyperdensity exudates will be present at the basal cisterns. When you get a CT contrast, you can see the basal cisterns will be more enhanced. Because of this compression, as we already discussed, they present as hydrocephalus. Then the other modality, when you get into MRI, in T1 axial, again you can see there would be iso intense exudates at the basal cisterns. In the flare, you can see bright sulci and cistern. In T2 flare also, there will be tracking along the perivascular spaces. And the contrast would be the most important because it gives a leptomeningeal enhancement. And when you get in contrast, the classical appearance is the spider leg appearance. You can see the marked enhancement of the inflamed meninges in the basal cistern. It is called spider leg appearance. As already discussed, the meningeal enhancements in HIV or AIDS patient, there will be little less when compared to the other cases. Coming to the from meninges, when it moves into the parenchyma, they present as tuberculoma. So tuberculoma is a granulomatous. You can see from meninges now it has moved into parenchyma. The granulomatous parenchymal lesion form the hematogenous seeding. It may be solitary, usually solitary. Sometimes it may present as multiple also. Again, the clinical presentation, because it's a parenchyma involvement, there will be present as seizures, headache, focal deficits, and raised ICP and mass effect. We'll go into MRI characteristics. In T1, how do they present? They present as iso to hypointense. In T2, there will be hyperintense. In contrast, there will be nodular enhancement. Again, in tuberculoma, whether it is non-caseating, caseating, or liquefied, it varies. If it's a non-caseating early, they'll present as T1 as hypo, whereas in T2, hypo. Where this is the most important. If it's a solid one, they become hypointense. That is the only major difference when you go into the tuberculoma. Based on the stage, the MRI findings also will be variable. As we already discussed, based on the caseating or non-caseating tuberculoma, the T1, T2 weighted images, they change. Then when this tuberculoma presents for longer time, they turn into brain abscess also in the parenchyma. How do they present? Again, they present with fever, headache, focal neurological deficits, and in the later stages, they have raised ICP, seizures, and altered sensory. So here in this image, you can see there will be multiple. Two abscesses are located in the right temporal lobe. The T1 weighted image is hypo. In the T2 weighted image, you can see that hypo intensity with multiple edema images. In SWA, there is no bleeding pattern or anything. In the flare, you can see the disproportionate edema is seen. And in contrast, you can see the brilliant ring enhancement is seen in TB abscess. The other pattern is hydrocephalus. As I already showed the images of the hydrocephalus, the management again would be simple with ETV, VP shunt if ETV fails. Tubercular vasculitis. Again, I'll jump into the cases directly after just the introduction of the tubercular vasculitis. They invade the subarachnoid space, protruding into, as we discussed, in the intense basal exudate, and in case they influence the adjacent vessels. So in MRI, they show acute territorial infarcts in basal ganglia and thalamus. Vessel wall enhancement and post-contrast T1 is very classically seen in this tubercular vasculitis. When it involves the basal cisterns and the exudates, they compress the cranial nerve. They present with the cranial nerve 6 is the most commonly involved because they present with abducens palsy, lateral rectus weakness. Next is when from the brain, when they move to spinal tuberculosis, most common they present as pot spine. In pot spine MRI, the most commonly affected vertebrae are the lower dorsal and lumbar, followed by the cervical. Atlantaxial regions are very rarely involved. The classical finding of any tubercular spine is they spare the intervertebral disc at the first and only involve the vertebral end plates. Then in the later stages, the paraspinal extension is frequently observed, complication that may result in abscess formation. In the more advanced stages, they can progress to kyphosis, cord compression, and then the present as vertebral body collapse. So in imaging, what do we see? In T1, there will be hypo. In T2, there will be hyper. In initial phases, as in destruction, it progresses, there will be vertebral body destruction and formation of abscess. So thin, smooth, enhancing paraspinal and intraosseous abscess features are of the spondylitis. And the CT scan, as already discussed, shows bony destruction. But when it's in a pyogenic abscess, as already said, in TB spondylitis, they spare the disc spaces, whereas in pyogenic, they first affect the disc space first and vertebral end plates. And they involve more than two vertebral bodies in cases of pyogenic abscess. So imaging differential diagnosis for this slide would help us. See, in tuberculoma, the axial T1 post contrast image, it shows a thick irregular ring enhancement, and T2 will be hypointense, and the target sign basal location is most common. Whereas in glioma, when you compare to the tuberculoma, it will have an irregular infiltrative margins, and it will be heterogeneously enhancing, and it always crosses midline and white matter tracks. Metastasis compared to tuberculoma, there are usually multiple ring enhancing lesion. They are located at the gray matter white junction, and there will be disproportionate vasogenic edema. Again, in neurocystic sarcosis also, there will be multiple. Cystic lesion will be there with eccentric scolix, thin wall, and minimal edema, and multiple as discussed. In pyogenic abscess, DW, as I said, DW plays a major role in pyogenic abscess because central diffusion restriction will be there. Smooth thin ring enhancements will also be there, and marked surrounding edema will be present in cases of pyogenic. I'll go through few cases, case bullets. This first case was 28-year-old female. She was a school teacher. She had no comorbidities and no previous history of tuberculosis. She was not immunosuppressed, and there was no medical significant illness. Her chief complaints were headache for 2 months, which was intermittent vomiting for the last 3 weeks, and focal seizures involving initially in the first left lower limb for 2 episodes. And she had 1 episode of GTCS. And the weakness slowly progressed into left lower limb and upper limb since 1 week. And when we examined her, GCS was 15, cranial nerves were normal. Motor power, it was 4/5 in the upper limb and lower limb. Reflexes were brisk. Plantars was extensor. Fundus early papilledema changes were seen, and there were no meningeal signs as of now at present. Again, the clinical timeline, 2 months before she had bifrontal headache, then she started with vomiting, then left lower limb weakness. These are the same thing which we discussed. She had no fever, no chronic cough, no weight loss, no previous tuberculosis, not a known immunosuppression, and she was viral markers were negative. Then we got an imaging done. Imaging, you can see in T1 weighted image, it was a hypointense. T2 was also hypointense, flare with an disproportionate edema, and contrast, it was enhancing with the central hypointensity. Extensive vasogenic edema was there, and there was mass effect and compressing the right lateral ventricle, and the 6 mm midline shift was there. Had you shown this only MRI, then I would favor more towards glioblastoma or GBM would be first diagnosis because of the thick irregular enhancement and central hypointensity. Then we had a multi-discussion. Radiologist was more, again, solid ring enhancing lesion with a broad differential diagnosis. It was between glioma versus abscess. My concern of being a neurosurgeon, it was more because of the significant mass effect, and tissue diagnosis was required. CSF was non-diagnostic, and infectious disease empirical ATT without tissue diagnosis may delay the treatment. So we needed a histopathological confirmation. We went ahead with the surgery. Why surgery? Because it was progressive neurological deficits were present, large space occupying lesion, significant mass effect, diagnosis was uncertain, and tissue diagnosis was essential in these cases. So we went ahead with the surgery. You could see bifrontal craniotomy was done. And you can see the locule over there. And as soon as we opened the dura, we could see the pus locule, which we aspirated. And histopathologically, it shows granulomatous inflammation with epithelioid histiocytes and Langerhans type giant cells were present. And histopathologically, it was diagnosed as intracranial tuberculoma with gene expert culture and ZN stain. And outcome and follow-up, and the immediate post-operative, you could see that lesion was completely excised, and 3 months after initiation of the ATT, it was completely relieved. And post-op day 1, headache was completely relieved. Day 3, power improved to 5/5. 6 weeks, ATT initiated and continued, and no recurrent seizures. 3 months, their MRI showed complete resolution of edema. 6 months, she was returned to work with no weakness. MRS was 0. So What I learned in this case was intracranial tuberculoma can closely mimic high-grade glioma or abscess, and imaging was non-specific. Clinical suspicion is crucial in endemic areas. Early surgical intervention not only relieves mass effect when it is present, but also provides definitive diagnosis. HB, AFB stain, culture, and gene experts are essential for confirmation. Timely diagnosis and treatment lead to excellent neurological review. The second case was also same. He was a 28-year-old male. He had headache, vomiting, ataxia, diplopia, sudden deterioration, and when he presented to us, he had an acute neurological deterioration with GCS of 12 by 15. MRI, we got an MRI in posterior fossa. It was a well-defined ISO2 hypointense lesion. So we differential diagnosis were usually in the posterior fossa. We go with the pilocytic, hemangioblastoma, very rarely metastasis, brain abscess, and tuberculoma. We had a discussion again since there was CSF was negative. Then we wanted, since there was also mass effect which was compressing the brainstem, we have went ahead with the surgery and removed the lesion. Here we could see in pre-op baseline MRI was this one. Post-op there was complete excision of the lesion. One month post-op follow-up MRI, there was no mass effect on the fourth ventricle, and 6 month follow-up also there was no recurrence. Histopathology also confirmed tuberculoma. Clinical outcome, patient neurological improved 15 by 50. Diplopia completely resolved by 2 weeks. Ataxia significantly improved, and he was walking independently by 3 weeks. And the spinal tuberculosis, because of the time constant, I'll run the fast. Because this was a 48-year-old male, you can see the D7, D8, there was a compression and the complete collapse of the vertebral bodies. See, D7 and D8, there was completely collapse of the vertebral body, and there was compressing the cord with the D7 and D8. Again, we had the same discussion. It could be discitis, metastasis, lymphoma, and brucellosis. We evaluated everything. We went ahead and removed the laminectomy D7, D8 and fixed with D5, D6, and D9, D10. Our goal was the surgery for the neural decompression, mechanical stabilization, deformity correction, eradication of the infection, and definitive diagnosis. Once the tissue was confirmed with tuberculosis, we started ATT for continued. ATT was continued. Within 3 months, there was neurological recovery, and 6 to 12 months, there was independent ambulation, solid fusion was present, and returned to normal daily activities. This was the last case. I'll not take much of the time. So this was 48-year-old male. He had C5, C6 fiction done 15 years back elsewhere. And suddenly he presented with neck pain on the since 7 days and right radicular pain. He had loss of appetite and also weight loss. His examination, it is presented as afebrile, but he was febrile, conscious, and he was oriented, and he had upper limb weakness of 3 by 5, lower limbs 2 by 5. In MRI, you could see C4, C5, there was vertebral body dissection with prevertebral collection from 3 through C6, and retropharyngeal abscess was present. When we examined him, you could see the swelling was present at right sided of the neck. We went ahead with surgery, and previously he had C5, C6 fixation was done. When we got a scan done and X-ray, you could see the plate was coming out, and it was compressing the esophagus. It was almost tearing the esophagus parapharyngally. It was coming out, and it was loosened. We first aspirated the collection. It was completely pus. We could see it when we aspirated, and this was the plate intraoperatively for the C5, C6. Here you could see. Here in this diagram, you could see it was the Ryle tube was coming out of the esophagus, and we repaired the esophagus completely and covered it with the sternocleidomastoid, and did a caging later on. So at day 1, he was hemodynamically stable, and day 5, when we did a contrast value, there was no contrast leak, and we resumed oral feed slowly. And by the time of discharge, his wound was healthy. 6 weeks, he was normally swallowing, and 6 months, it's an excellent outcome. So this was when we go to the literature, they say anterior spine cervical surgery with a poor prognosis, then they present as tuberculosis. They require revision surgery. When they use a sharp retractors, then there may be a direct injury risk to the esophagus. So you should identify them, recognize them early, take the immediate help. Primary repair should be done with both surgical gastrotomy and neurosurgery. When early recognition was there, prompt management, greater than 85 to 95% of successful outcomes were reported in these cases. So neurological manifestation and imaging in neurotuberculosis is not a single disease. It is a spectrum of neurological emergencies. So early suspicion, think of TB in unexplained neurological syndrome. Neuroimaging, interpret MRI in clinical context and recognize the patterns. Always require a multidisciplinary approach, and surgical management will be essential in cases of where the patient is progressing and having a neurological deficits. MRI may reveal the lesion, but it's a clinical judgment that saves the patient. So early diagnosis prevents the disability, timely surgery restores the function, and collaborative care changes life. Thank you, everyone.
Thank you, Dr. Vamshi Krishna, sir. That was an excellent review of the neurological spectrum and imaging characteristics that every clinic